Hi there. My name is Kenneth Ngetich. I'm a nurse practitioner student, and I have a portfolio project presentation regarding um, palliative and hospice care. Welcome. So today I have JR. She's 89 years old, female. Um, she's a DNRCCA code, and Miss JR is a former high school teacher. She's divorced, um, and she has 5 children, 3 boys and 2 girls. And out of the 5 children, one is in the state, living with the daughter in the state. The rest are out of state. Um, she um, she live in independent senior living, and that's where she stays. The daughter um, made an arrangements for the um, an assistance with ADL aid with ADLs, and she usually visit 2 to 3 times a week. Um, so um, briefly, the history of Miss JR. She's a former smoker. She's had smoked for 45 years, but currently she quit, and she has a couple of history, like she has acute. She's had acute pyelonephritis, CHF, chronic high blood pressure, IBS, COPD, um, hernia without obstruction, depression, and GERD. Um, the past surgical history, she's had a right ankle surgery, back surgery, cholecystectomy, um, EGD back in August uh, 2008, right foot surgery, abdominal hernia repair, uh, triple A repair. That was in May of 2010, and toxectomy. She, Miss JR, is able to ambulate with a walker. She need help like with the ADLs, and a lot of time is four. She's able to tell. I mean, she knows what's going on and everything, but she's declining, kind of frail, and most of the time she'll need assistance. So I'll focus today on the 3 conditions: terminal, CVA, COPD, um, and CHF. So pretty much CHF and COPD are really, making a decline. She's on continuous oxygen, 4 liters, but still shortness of breath. She's starting at, when I was with her, she was starting at 80, 88, 85, I mean 87, 80, 88, not to 90, but she's on 4 liter oxygen. That's a lot. So Miss JR is I I sat down and I spoke to her, and she told me she uses inhalers to help with breathing, shortness of breath, and uh, hydromorphic narco um, twice a day as needed for pain. So that's briefly about Miss JR. So regarding the what she has or what she opted for, she has a advance directive and a living will, and she appointed her daughter, um, a young daughter who lives in the state. Her name is JC. Um, she's the only child who is close and make decisions for her. So JC is the trusted daughter who is, uh, in our opinion, too close to her and responsible to make decisions for her in the event anything emergency happens. Yeah. So regarding the family involved and other agents about the living will or the advance directive, she appointed, like I say, the daughter, who is JC, as the sole POA who make decisions, and already consulted the doctor about the condition because she's declining, and she no longer wants to have all this aggressive treatment to to sustain her life. She already spoke to the pastor about her condition, and declared her wishes medically. Um, she had initially she told me she had a meeting several years ago about appointing a power of attorney, and it was controversial, contentious because of when the children got together and they were not able to agree. But at some point, it took them a couple of years before they agreed. But finally, they were in agreement, and they appointed JC as the POA. So the barriers in completing this discussion with Ms. JR, yes, I had kind of challenges. Yes, discussing a living will and advance directive is a sensitive subject. I had to consult with the POA, who is the daughter, JC, and explain why I was interested in advance directive conversation. They were not. It took me time to convince them to accept to participate in this interview and conversation. I promise confidentiality and privacy on this matter because it's sensitive. It took me about 3 days to complete my interview with this patient. Regarding the document that the patient had, she had already completed, the living will and the advance directive. So she had that one. She already had it. So in the advance directive, a couple of things were there. She was able to show me the document, and we talked about it. We discussed, and we went through everything. So JL had an executed and notarized living will and advance directive. The document is pretty much comprehensive. Everything is, stipulated there and well documented. Yeah, the patient had, the durable power of attorney for health care, naming our daughter, JC, as the sole agent who can make decisions about medical care. So when we went through the the living will, and we each and every area, she pretty much answered all the questions, like with the CPR, she no longer wants CPR. Her condition is decline. She's declining due to the uh, these chronic terminal conditions. Um, Breathing, she told me, is one of valuable thing that for any human being, and suffering, having trouble breathing has been really a big challenge, and accumulating of fluids in lower extremities and coughing, and has been so hectic. And being 80, you know, being 89 years old, she felt like she was ready. Like, I mean, she didn't want to continue suffering again, and pretty much she's at peace. She just she's ready. So she, with the CPR, she don't want it. She declined. Intubation, she don't want to be intubated. She don't want any dialysis in the event the kidney shot. Transfusion, blood transfusion was also another thing that she told me she don't want it anymore. She's too old for that, and you know, hydration. Pretty much, she says she don't mind to be hydrated and kind of a little bit save her life. And about the surgeries, she says she no longer need any surgeries. At our age, is she don't want it. Hospitalization. She the last for the last um, for the last 6 months, no, 4 months. She told me she had been hospitalized about 6 times, and with the complication of CHF. So hospitalization, she's okay with hospitalization, but she only want comfort care. She don't want like aggressive treatment. You know. Regarding the medication, she is still taking her medicine. For now, she's okay with taking medicine. About the implantation of cardiovata or defibrillator, she don't want it. She declined that one. So the decision making capacity in the event she no longer able to do that, the POA JC is to determine what is best. She told me that what is best for her in the event she's incapacitated. The healthcare proxy, she's still JC, who is a POA. And with the palliative performance scale and Karnoskov scale, I'll put our PPS as palliative performance scale at 70%. She's still able to ambulate, those kind of not much. Can do OBs and some home occasionally need assistance, and poor intake. Level of consciousness, she's okay. She's a lot of times 4. She's 4. Yeah, and I think you enjoy. Thank you.